coming. So today I am excited to share my work on consumer health information justice. That phrase I've adapted from the phrase health justice, which is the idea that every individual is morally entitled to an equitable and sufficient capability to be healthy. So we'll be talking a lot about that throughout the talk. So I'll start out just with my cover slide. I really like this quote from Dr. Martin Luther King Jr. It really represents what I'm trying to work on and work to resolve and address. So this talk, I was thinking at first we could spend the first part of it doing a little background information on health justice, and then dive into a study that I and a couple of my doctoral students conducted relatively recently, and then I was going to go into my current work. First is just trying to model consumer health information behavior and how maybe consumer health information behavior might mediate the relationship between different demographic factors and then different types of health outcomes that have been found to correlate with certain demographic factors. And then the next two things that I just was going to briefly mention, one is a special issue that we just completed of the International Journal of Information, Diversity, and Inclusion on the topic of health justice. And we got many excellent submissions. In fact, we did two issues because there were so many excellent submissions, and we wanted to share them. And then the last thing is a current, it's not done, we're working on it right now, and we invite you to submit a chapter proposal if you're interested. We're working on a volume of the Advances in Librarianship book series focused on the topic of roles and responsibilities of libraries in increasing consumer health literacy and reducing health disparities. And later on in the talk, you'll see I have a link to both the Advances in Librarianship book series, just to give you a general idea of that series, and then a link to our call. And if you're interested, just ignore the deadline. You're welcome to still submit. So I'll talk a little bit about that. Okay, so first a little bit of background. So the motivation behind my work really focuses on social injustice, which is, you know, if you're an individual or part of a group that experiences social injustice, you have limited access to resources and opportunities, and you're more likely to become ill, to get injured, and to die prematurely if you're experiencing social injustices. But what I am excited about is I really feel like information professionals and information can help with this situation. And, you know, we're not only resources in and of ourselves, but we can also serve as stepping stones that help people to learn about and take advantage of resources and opportunities that are in their lives. And we need to ensure that people have equitable access to resources and opportunities so that their chances of living a long and healthy life are as optimized as we can make them. So this concept of health justice is not new at all. So reaching back all the way to 1946, the World Health Organization talked about the right to health, basically saying everybody has a right to the highest level of health that is attainable for them. And this is really linked to what are often called the social determinants of health, including many things, but among them housing, education, nutrition, employment, environment. And then another organization that has worked on really health justice is the UN Committee on Economic, Social and Cultural Rights, which is a UN body of 18 experts that monitor UN members' compliance with the International Covenant of Economic, Social, and Cultural Rights, which was adopted in 1966. There are 169 parties to this covenant, and in addition, 4 countries have signed, but they haven't ratified the covenant, and this includes the U.S. The idea behind the covenant was to ensure people's many different kinds of rights, including right to education, right to an adequate standard of living, labor rights, and of course, right to health. So this particular document, General Comment Number 14, and I have reference slides, and when Curie distributes the slides in probably a PDF format, you'll be able to have the reference slides. And it'll.
Hey Beth, I'm going to cut in for just a minute. Is that okay?
Sure, of course.
Someone asked me to ask you to slow down just a little because your sound is kind of muffled.
Oops, sorry. Okay, I will do that. Thank you.
Sure. Thanks.
Yes. So this general comment number 14 emphasizes that health and healthcare facilities, goods, and services must be available, accessible, acceptable, and scientifically and medically appropriate and of good quality. And I just wanted to delve further into accessible. That's why I put that one in yellow. And so this comment calls out 4 different dimensions of accessibility, including non-discrimination, physical accessibility, economic accessibility, and information accessibility. And that last one, the general comment particularly called out information access, pointing out that it's really of very high importance in relation to people's health. And then jumping into one of the other topics that'll come up, of course, a lot in this webinar is health literacy, because information access isn't just physical. If people have physical access but they don't have intellectual access, if the information isn't comprehensible, then the physical access doesn't really help. And so just a brief little bit on health literacy. It's basically the capacity to get a hold of, to understand, and to apply health information in order to make informed decisions. We have a lot of adults in the U.S. that have below proficient level of health literacy. This study from Kuttner, I'm not sure, found that nearly 90% of adults in this country have a below proficient level of health literacy. And disadvantaged populations they have a higher likelihood of having lower health literacy, so including people who are older, people who belong to a minority population, people who have lower incomes, and people who are less well educated. And the reason that is important, or one of many reasons, is that studies have found that people who have lower health literacy, they're less likely to get preventative care, and they're more likely to be hospitalized, to use emergency services, and to have poorer health outcomes. And studies have found a strong connection between limited health literacy and health disparities. This one study in particular, the Weiss one, they found that health literacy is actually a stronger predictor of somebody's health than an individual's age, their race, their educational attainment, their employment status, or their income. So that really underscores how important health literacy is. And so information, I really emphasize in the CHIJ, the Consumer Health Information Justice. I really emphasize the information component in my research. because I feel that it plays a fundamental role in creating and perpetuating health inequities and health injustice, but at the same token, I think that it can also play a fundamental role in helping to reduce these health inequities and to move us closer to health justice. I really draw heavily on this. This is a book by Venkatapuram, and it's a really interesting book on the capability approach to health justice. And so the way he defines health justice is that every individual is morally entitled to a sufficient and equitable capability to be healthy. We can't guarantee health to everybody. We can't say you should have 5 units of health. Everybody gets that. But we can guarantee the social bases of health. So health is valuable not only just in and of itself, of course, but also it enables people to do other things, to make a living, to protest unjust conditions, for example. A person's capability to be healthy is significantly socially produced. So the social bases of health disparities we'll talk about a lot. And this capability to be healthy is a meta-capability in that it's an umbrella. There's many abilities rolled up in the capability to be healthy. And both Venkatapuram and another author that I'll talk about in a little bit really emphasize that the health justice is really not just about being healthy, it's actually about being able to flourish in your life. Okay, so does health justice exist? No. In the U.S. it does not exist. It's not the case that everybody has fair access to the resources and opportunities that will enable them to live a long and healthy life. One way that we might measure health justice is to look at life expectancies. Studies have found that people who have a higher income, who are better educated, and who are white live on average 10 to 15 years longer than other people. And the really scary thing about this is that these gaps are not getting better, they're actually getting worse over time. So these two sets of authors, CHIB and Olshansky, both found that these gaps are actually getting worse. Okay. So causes of health disparities. So it's not just related to like access to care, quality of care. Healthcare is definitely important, but there's also other factors, and including different social determinants of health, which the World Health Organization defines as the conditions in which we are born, grow, live, work, and age. And Ruger's another author that writes on health justice. And sometimes some of the work to find the work on health justice, they may not call it that, they might have called it social justice, and so you kind of have to search for social justice and the word health to get some of this work. So both Ruger and Venkatapuram emphasize that our focus needs to be on not only the right to health, but the right to flourish. And at the very minimum, we're talking about the ability to avoid premature death and to prevent preventable disease. So to live a long and healthy life, people need many things, but among them is definitely access to information, and that's where I focus in my work. So the bases of health depends on both individual and societal factors. So from the individual viewpoint, things like biological endowment, changing needs, for example, as we age, our behaviors, and then societal things like the physical environment and the social conditions. And there are definitely certain types of social arrangements that lead different groups of people to suffer needlessly and sometimes even die prematurely. One of the things that Venkatapuram points out is that when you're talking about one of the bases of health being people's individual behaviors, that sometimes people blame people for their disease. So some of my early work, I worked with people who have type 2 diabetes, and this came up a lot, feeling blamed and shamed, and there was a lot of stigma they felt around diabetes. And Venkatapuram points out that sometimes people blame each other and they say, well, you behaved this way, so you got this disease. This quote in the box is something actually from my one of my participants in my dissertation research who has type 2 diabetes, and she's basically saying that she felt like blamed, and she says, you have diabetes, you don't have support for having it, and so why bother? So this is a big problem. But what Venkatapuram goes on to point out is that, you may feel that way, like I don't want to pay for people who didn't behave well or whatever, didn't make the good choices. But what he emphasizes is that we can only make the choices that we have access to. We can't make choices that, maybe perhaps we don't have a lot of money and, we can afford the McDonald's, which isn't the greatest for us. And so we have to keep that in mind, that the choices people make depends on what choices they have available to them. So different social arrangements can constrain people's ability to be healthy. And Venkatapuram points out, he says, we're going to need to be able to say that, yes, we've treated people with equal concern and respect, but if they have a preventable disease or a risk of premature death, have we really done that? So unjust social arrangements can lead to avoidable illness and premature death, and these factors, the illness and the premature death, can prevent people from pushing for social change, and so people may get stuck in unjust social arrangements, and sometimes even through generations, generation after generation. And so Venkatapuram mentions that every person is morally obligated, at the very minimum, not to constrain other people's capabilities to be healthy. But he goes beyond that and says we have a responsibility to use our abilities and whatever powers we may have to address past harms that have been made to individuals' capability to be healthy, and to protect, promote, and restore everybody's capability to be healthy. And then I really liked this quote that he had, that yes, definitely we need healthcare policy to be right, to be able to achieve health justice, but we also have to get social arrangements right. Okay, so now I'm going to just jump into the study. So this was a study that I and a couple of my doctoral students worked on. So we were curious. We were curious if there were any relationships between the information behavior of avoiding information, like I don't want to see that, don't tell me about that. So whether there were any relationships between information avoidance, health literacy, and health justice. And so our research questions, number one, we just wanted to know how prevalent is information avoidance. A lot of the literature makes it sound like it's not that common, it's sort of an anomaly. So we were just curious. And then the second question we had is, what are the different kinds of factors that are associated with information avoidance? Are there any patterns in the groups of people, the people who are wanting to avoid information? So a lot of people, when they're diagnosed with an illness, they cope by seeking out information. but sometimes people don't, and it has some benefits, like it may enable somebody to either maintain or increase their uncertainty, which you may want to do if it's, you know, perhaps you have a very serious diagnosis, and it might feel better to be more uncertain. Sometimes people avoid information to try and control their anxiety or to maintain their hope. And information avoidance can both result from and result in low health literacy. Okay. Information avoidance has been found to have some negative consequences as well. So receiving less information from providers, being unable to take a full role in informed treatment-related decision-making. And one of the studies I read talked about that people who were trying to avoid information were sometimes treated paternalistically by their providers, and were ultimately, in the end, less satisfied with their health decisions. This was around their treatment decisions for breast cancer, so they regretted their decisions later, some of them. So we first looked at the literature, and we found that, well, information avoidance isn't all that unusual. So one study found that over half of the participants in their study preferred to be told the best possible diagnosis rather than what was most likely for them. Another study, the Wong one, found that about 20 to 25% of their participants, which was men with prostate cancer, preferred to be told the best possible outcome. About 10% wanted to be told the worst possible outcome, and about 2/3 wanted to know the most likely outcome. And then Ramadad and Viswanathan found that nearly 1/3 of the people they talked to with cancer said they don't look for information concerning it. And Freimuth et al. Found that up to 20% of women who had had a mastectomy avoided any cancer-related information in the first year after their treatment. So what we did for our study, the National Cancer Institute puts out this data set, the Health Information National Trends Survey, and that data set is completely free. If you go to that link in the orange, you can go and get it and download it. They have it in, I think it's SPSS, SAS, and Stata, so you can pick whatever format you'd like. And it's really clean and really well documented, so it's really fun to work with. And this particular data set, it was from 2014. They had 3,677 survey respondents. It's just a nationally representative sample of U.S. adults. And then we did some statistical analysis, and we really focused on one survey question. They asked people, how much do you agree or disagree with the statement, "I'd rather not know my chance of getting cancer"? And that's how we defined information avoidance for this study, was if they said, yes, I'd rather not know, that we defined that as avoidance for the purposes of this study. So what we found is that almost 1/3 said, yeah, I don't want to know. I'd rather not know my chance of getting cancer. 10% strongly agreed, and 21% said they somewhat agree. So then we dove into, okay, who are the individuals that are saying, yes, don't tell me? And what we found is that among the people who preferred not to know their chance of getting cancer, they tended to be older, they tended to have lower educational attainment, lower household income, they tended to be unemployed, disabled, or retired, and they tended to not have health care coverage. And all of these differences were statistically significant. This just shows, the next few slides just show visually those findings. So in this one, we can see that the older participants were more likely to say, yes, don't tell me, I don't want to know. So 75+ particularly. And then this one, shows by education. So you can see that the folks who had less than 8 years of education, almost half of them said, don't tell me, I don't want to know my chance of getting cancer, versus people with a post-grad education, it jumps up, jumps down to just a quarter of them said, don't tell me. And then by income, so looking at the lowest income bucket, so making less than $20,000 a year, 40% of them said, I'd rather not know. And then if you go up to the 75,000 or more income group, then it's down to a quarter saying, I don't want to know, don't tell me. So these are all the other additional factors that were found to correlate with not wanting to know. There were many of them, and these are all statistically significant. But you can see from the list we've talked about so far in this list that there seem to be sort of markers of disadvantage that keep coming up in this group of the people who would prefer not to know their chance of getting cancer. So from this list, you can see, like, never going online, not having broadband access, not owning a tablet, a smartphone. We're going to walk through a few of these here. So just in terms of internet access and use, the people who said, I don't want to know my chance of getting cancer, were more likely to never go online, to not use broadband, to not own a tablet or a smartphone, to not have health apps on their devices if they did own any. And then findings regarding health information seeking, the people who would rather not know tended to have never looked for information about health from any source, and then same thing for cancer in particular. And of the people who had looked for cancer information, they were more likely to say they'd encountered barriers. So things like, the search took me a lot of effort, I felt frustrated, I had trouble understanding what I found, or I was concerned about the quality. They were also more likely to agree with the statement, there are so many different recommendations about preventing cancer, it's hard to know which ones to follow. Some of the other things we found, just briefly, they were less likely to trust doctors, government health agencies, and the internet. They also had lower health efficacy and lower information efficacy. So health self-efficacy, they were less confident in their ability to take care of their health. And then information related, they were less confident in their ability to get advice or information about cancer. And this just kind of shows that relationship visually. Health beliefs, what we found is that the folks who said, don't tell me, I'd prefer not to know, they tended to feel that, like, health behaviors don't matter. So they felt like diet, exercise, or smoking play little to no role in determining whether someone will develop cancer and some other diseases. They were more likely to agree that quitting smoking wouldn't help to reduce harmful effects of smoking. More likely to say it seems like everything causes cancer, so there's some fatalism, and there's not much you can do anyway to lower your chance. This shows it visually. They are more likely to be smokers, less likely to say that they use calorie information when deciding what to order in a restaurant. And then there's a few other ones that are they're interesting, but I'm not sure why they occurred. But one of the things that we found is that the people who preferred not to know, they believe that cancer is common, but they believe that they personally would not get it. And there were also some, like, disadvantages around social support. So they were more likely to say that they did not have someone they could count on for emotional support, and that they didn't have friends or family members they could talk to about their health. And they also were more likely to say that they don't have a particular doctor or health professional that they go to most often. And then another thing we found is that they they didn't prefer the collaborative decision-making with their doctors. They preferred either the two yellow ones, to make the decision with little or no input from their doctor, or to leave all decisions about their treatment to their doctor. So it sounded, you know, from our findings, it sounded like there were different kinds of factors that were associated with information avoidance, and that it also seemed to us that there are things that we can do to try to intervene between low health literacy and poor health outcomes. We were thinking that we could improve health justice, the state of health justice in this country, by increasing patients' access to health care, their access to good health information, and working with them to improve their health literacy skills, their information literacy skills, as well as their self-efficacy around both health and information, and with making opportunities for good relationships with their healthcare professionals, and then as well as beyond individual patients, also trying to work on barriers, institutional and structural barriers that can impede people in getting their care. And so the last third of this presentation is just on more current work that's kind of messy right now. What we've done is we took what we learned from that study, and we're trying to build, we're tentatively calling it a consumer health information behavior model of health injustice, to look at some potential links between consumer health information behavior and health justice or health injustice. So how might consumer health information behavior mediate the relationships between demographics and other types of factors that we were just mentioning and health injustice, and then how can we use that information to identify not only like causal pathways, but also solution pathways to prevent and reduce health injustice. So just visually, what we're trying to do is we're saying, okay, you know, many studies have found that various individual factors are associated with various health outcomes, for example. So in the orange, you might have people who have lower incomes, and then in the green box, you have that they have poorer health outcomes. And so we're putting consumer health information behavior in the middle of this equation. There's probably a million other things that go there as well, but just because that's my hammer, my area, that's what I'm looking at. And so what we've done is we've taken what we learned from that one study and built a model off of it. And so the individual factors in number one box are all the stuff we were just talking about, all the factors that correlated with not wanting to know one's chance of getting cancer. And then in the blue box on the far right are the health outcomes, basically quality of life. And in the middle is the whole consumer health information behavior process. And so the next few slides just sort of step through each of those boxes and what's in them. And so the process here, I think it's really important to include not only like the active things, like the kind of traditional what you see in an information behavior model, like need, seeking, use, that it's also important to include things like incognizance, information avoidance, and information non-use, where incognizance is having an information need but not knowing that you have it. And so if you're incognizant, it's going to be hard to identify that you have an information need and definitely to articulate that. So these arrows are drawn in dashes to show that these transitions may or may not happen. And then if you do identify a need, maybe you go on to seek information or perhaps you avoid it, and then you work on information comprehension, assessment, management, and then perhaps incorporating it, adapting it, using it, or perhaps not doing that, not using it. And then the health outcome box, and then sort of underlying the whole model, I'm just going to flip back for a minute, is this thing at the bottom, the situation / context. And so those are the resources and the opportunities that the individual has, as well as the limitations and barriers they face within their day-to-day lives. And it's not only their actual resources and opportunities and their actual limitations and barriers, it's also important what their perceptions are. So if they perceive that they have opportunities or they perceive that there are barriers, so that's really important, as well as the actual. So we're working on this. It's a bit of a mess right now, but we know there needs to be some more things in there. And right now it's just built on our study, and we want to take some work from other studies in this space and start adding to it. One of the things that we've done most recently is add the blue box at the bottom, which is different kinds of it's factors about sources, but it's also how the source intersects with the individual. So these are things like source awareness. What sources do people come across in their day-to-day life? What are they aware of? What do they see? What's their everyday exposure? What are their perceptions about different sources? Do they trust the sources, for example? What is their past experience with a source like? That's another super important part of it. But we're working on this. So, this is sort of what we're basing our work on. That we're calling it consumer health information justice. We're just coining this phrase, and we're focusing on that. For a person, an individual, to have a sufficient and equitable capability to be healthy, they need many different information-related factors, including access to health information, awareness of sources, ability to identify and articulate a health need, health literacy. There's many more, and people's information behaviors play a central role in shaping what is possible for them and what actually happens as far as their health trajectories or health outcomes. And so information-related factors influence whether and to what extent a person will experience either health justice or health injustice on a scale. So we have an opportunity and a responsibility to help to shape these types of information-related factors so that we can optimize every individual's capability to be healthy and to flourish by many different methods. But these are some ways, like increasing their awareness of sources and their access to sources of good health information, improving their health literacy skills, removing barriers such as not having a trusted healthcare provider, not having healthcare coverage, learning about self-management, like with chronic diseases such as diabetes, and also to reduce health disparities by trying to take down some of these barriers that can constrain people's ability to live a long and healthy life. So the last two things are just two publications that we've been working on. The first one is this special issue of the International Journal of Information, Diversity, and Inclusion. So we put out a call for people who would be interested in writing an article on the topic of health justice. We got a lot of really excellent submissions, and so this ended up being a two-parter, so two issues, and there's links to both of them down there in orange on the bottom right. And when we put out the call, what we asked for the focus to be was any types of information-related factors and processes that are central to achieving health justice, including this list here, among others. So we were open to whatever we might find. I'm going to just highlight three of these articles that seem particularly relevant here. So this first one is a piece written by Emily VARDELL, who's an assistant professor at Emporia State University, their School of Library and Information Management. So she conducted a literature review to identify the various types of factors that influence people's health insurance literacy, and she built this model that she called the integrated framework for health insurance literacy, and pointed out that people's decision-making ability is influenced by their health insurance literacy, of course, but also by other types of factors such as things about aspects of their health plan, and also sources that are available to provide them with information about their options. So that's a really interesting article. There's a link there at the bottom if you want to jump right into that article. The second article I wanted to highlight is by MEHRA, who is a professor at University of Alabama School of Library and Information Studies, and one of his PhD students, Everett Scott Sikes, who is actually a student at the university BHARAT just moved from, which is University of Tennessee, Knoxville, and VANDANA SINGH is an associate professor at University of Tennessee, Knoxville. So the three of them worked on this. And so they were looking at how rural libraries are engaged in health justice. And so they interviewed 15 rural librarians from the southern and central Appalachian region. And these are their model here is the different health-related information offerings that those rural libraries are offering to their communities. So the different kinds of programs, screenings, et cetera. And then the last one I wanted to highlight, although there are many really good ones, so if you go to those initial links on that first page, you'll be able to see the full table of contents. But the third one is an article by Noah Lenstra, who is an assistant professor at UNC Greensboro, their Library and Information Studies Department, and Chris Darpa, who's an assistant professor at Wayne State University School of Information Sciences. And they conducted a literature review, and they were identifying the different ways that public libraries increase access to food. So what is their work around food justice, and they identified 4 different ways that public libraries are helping with food justice, ranging from distributing food at the library to teaching and enabling community-based agriculture, teaching how to cook, prepare, and eat healthy foods, and then they're also partnering with existing programs. And I just pulled out one or two examples of each of these here, but there's a ton more in their article. So if you're interested in food justice, I'd definitely go check that out. And then the last thing I wanted to mention is our current volume that we're working on. So it's a volume of the Advances in Librarianship book series, and our call is focused on the roles and responsibilities of libraries in increasing consumer health literacy and reducing health disparities. And some of the topics we mentioned, but we're pretty open again to whatever, reading whatever we get. So some of the sample topics are listed here, and ranging from consumer health information behavior, health literacy, social justice, patient narratives, technology design, community engagement. And so the blue link will take you to information about the book series, and the orange link will take you to our call for book chapter proposals. And as I mentioned at the beginning, if you're interested in this, don't let the due date deter you, because it is past. But we're definitely open to considering more book chapter proposals. With that, thank you very much, and please, I'm happy to take any questions. Thank you.
All right, thank you so much, Beth, for sharing all of this work. I do see that there is one question already in the chat, and it's from Carol. She said, were the questions in the survey on avoidance pre-selected, and why? She's wondering if anyone may have been more receptive to accepting information rather than avoiding it if they were in pain or experienced some level of pain.
That's a great question. Unfortunately, because it was a secondary data analysis, we were limited to whatever HINTS had asked the National Cancer Institute, and that was really the only question that had any similarity to information avoidance. But that's a great question, that if someone's in pain, they might be more receptive to. I wonder that analysis might even be possible. I don't think they asked about pain, but I think they did ask people to rate their health status, like how healthy they felt, and that would be really interesting to look at.
Thanks. So there's another question from Claire. Your model brought to mind the stages of change. Do you feel that incognizance is akin to an individual who is not ready to change, or do you feel incognizance is actionable and has potential for intervention?
Wow, that's a good question. I'm going to just pull it up here so I can remind myself. Okay, whether it's akin to an individual who is not ready to change, that's interesting. So where incognizance came from was my dissertation research, interviewing people who have type 2 diabetes, and where I saw incognizance were they described situations where they had an information need, but they didn't realize it. Just to give an example, it wasn't uncommon that they would find out they had diabetes because something happened, like they had a stroke, or like one guy explained that, I woke up one morning and my leg didn't work, and I didn't know, if it meant anything. I thought maybe I just slept on it wrong. And he said, I happened to have a doctor appointment that day, and so I went to it that afternoon, and the doctor tested his blood sugar, and it was so high that they actually called an ambulance to get him to the hospital. And so even though sometimes people had sort of, hints, I guess, that maybe something was wrong, they didn't realize until later, and so sometimes they didn't get information they needed until it was too late to be of the most use that it could have to them. But so it's akin to an individual who's not ready to change. That's interesting. I mean, I guess it could be that maybe if they were ready to change, they would be more able to recognize that they had that information need. That's interesting. And the second part of the question, do I feel it's actionable or has potential for intervention? Definitely. I kind of collected quotes from my participants about like what they thought would help with this. Of course, I didn't call it incognizance, but I just used whatever words they used to describe it. And the kinds of things they mentioned were, like one person said, the older people, and she didn't mean like older by age, she meant by like they'd had diabetes longer. The older people in the support group would ask questions that I didn't even know I should have those questions. And so if people can work with somebody who also is in the same boat and maybe is a little ahead of them in terms of not only like time gone by, but also able to successfully manage the diabetes. Like one of the support groups that I went to help recruit participants for my study, one of the women that went to it was 92 years old, and she'd had diabetes for about, I think it was about 40 years. And for her, like, she was just so inspirational because people really looked up to her, and she's basically going to die from something else. She's managing the diabetes. She's very successful, And so people all learned a lot from her because she was able to manage the disease.
Thanks. So we have another question from Carol, and I think it regards to kind of gatekeeping of information by healthcare providers. She said, can the providers be described as information avoiders or holders of important information, or biased in providing information due to perceived social arrangement of groups?
Wow, interesting. Yeah, that's a really interesting question. I think that can happen. There's a really interesting study done by Clark. When you get my slides, you'll be able to just look at the Clark 2005 study, and she basically studied people, women who have breast cancer, and she went to support group meetings for women who have breast cancer, and she went to, I forget exactly how many, but I think she went to 3 different support groups where the women were largely middle class, and like 2 different support groups where the women were largely working class. And it was really interesting to read about the differences in how they handled information. So whereas the middle class support group members, they tended to be really active information seekers, and they would become experts. They'd read up, they'd go to the library, they'd learn a lot, they'd work more collaboratively with their doctors, and they would basically kind of share information with each other and become like lay experts. And the working class group members tended to more hold up the expertise of their doctors and like, look, my doctor's so great, and really like they'd spend their meetings, instead of like sharing information among themselves, they would arrange the meetings that they'd invite doctors to come and talk to them, sometimes the same doctors over and over. And it was more about like supporting the expertise of their doctors. And some of those doctors, the things that they said to the women were kind of like you're describing, like they would say things like, no, you don't need to advocate for yourself. You just listen to me and I'm advocating for you. You don't need to go look for information. You won't understand it anyway. And so, don't bother with that, and just do what I tell you to. And those are the women that later tended to regret their treatment-related decision-making, because they felt like they didn't have the information they needed, they didn't get to participate in the decision because their doctors were just telling them. And sometimes the doctors would even kind of do it like sort of threateningly, like, you just do what I tell you to, or you're going to lose, your breast or something, and you've got to do it right now, or you're going to die, or something like that. And so those women tended to be less happy with the outcome of their decisions. Yeah,
all right, Beth, thank you so much. And we have a lot of further reading and further inspiration on your slides, which I sent to everyone at the beginning. So you can certainly take a look at that for more information and for more studies on this interesting topic. So as a reminder, today's presentation was recorded, and it'll be posted on the NNLM YouTube page as soon as possible. So you will get an email from me once it's been posted with the link to the recording. And to evaluate today's webinar and receive your MLA CE credit, please visit the link on this slide, which, if you give me a moment, I'm going to copy and paste into the chat box so you can click it right from there. So you must fill out the evaluation and redeem the code within the next 30 days to claim your CE. Again, thank you all for attending today's webinar, and a huge thank you to Beth for your time and insight. Have a great afternoon, everyone.
Thank you very much, Kiri, and everybody.